Hello everyone, I hope you all are doing good. Let's take a PYQ topic. Women presents with amenorrhea and history of frequent abortions. So here the woman is presenting with amenorrhea and frequent abortions. FSH is 7 and HCG is less than 5. What is the cause of amenorrhea? So here first the woman had recurrent pregnancy loss, then the woman end up in amenorrhea. So of course this is a case of secondary amenorrhea, right? And secondary amenorrhea has been asked quite many times in our last exam. They are giving one question on secondary amenorrhea again and again. In the last 10 exams, we have got a question from the secondary amenorrhea. So this topic is very, very important. Now, in the secondary amenorrhea, our first thing is whenever patient comes for the secondary amenorrhea, the first thing which we are going to do is we are going to rule out the physiological causes of secondary amenorrhea. The most common physiological causes pregnancy. How we rule out pregnancy? By the urine pregnancy test or beta HCG estimation. So here they have clearly given that HCG is less than 5. So it is not a case of pregnancy, right? Lactation. To rule out lactation, they must be given that there is a history of recent delivery. Since they have not given, so it is not a cause of, it's a cause of secondary amenorrhea is not lactation. Number 3, menopause. Menopause is ruled out by age. The patient age will be around 51 years. Since it is not that case, so it is not a case of menopause also, right? Now, after ruling out the physiological cause, we will come to the pathological secondary amenorrhea. First of all, we will see how the periods come and how the FSH level get affected in all those pathological secondary amenorrhea. Okay, so to have acts on the interior pituitary, which in turn produces FSH. Follicle stimulating hormone acts on the ovarian follicle and estrogen is produced. This estrogen peaks around the day 14 and gives negative feedback to the FSH. This estrogen, which was being produced by the ovary, acts on the uterus endometrium. The uterus endometrium proliferates, and when on the day 28, when there is progesterone withdrawal, this endometrium it sheds and periods come. Okay. Now, whenever there is amenorrhea, the cause can be that hypothalamus pituitary is not stimulating. There is failure of hypothalamus and pituitary, which is causing amenorrhea, right? Since hypothalamus pituitary will not stimulate, the patient will land up in amenorrhea. Now, in those cases, the FSH will be decreased. So, this is very, very important. What is the value of normal FSH? The normal value of the FSH is 5 to 8 international unit. Okay. Now, when the FSH will decrease due to hypothalamus pituitary failure, the FSH will be less than 5 and the patient will end up in amenorrhea. In case the hypothalamus pituitary were functioning normally, but the ovarian follicles have finished, or there was gonadal dysgenesis. Now again, the ovaries will not produce estrogen. Since the ovaries will not produce estrogen, the estrogen will not give negative feedback to FSH. So in turn, the FSH will increase and the patient will land up in amenorrhea. So in ovarian failure, the FSH increase, and now the FSH value will be more than 40 due to the lack of negative feedback of the estrogen. Okay, and in hypothalamus pituitary failure, the FSH decreases and its value is less than 5. Okay, now I told you that this estrogen which was released from the ovary, it acts on the uterus endometrium and proliferate. What if the uterus endometrium is not proliferating? There are any adhesions in the uterus which is not letting the endometrium to proliferate, like in the Asherman syndrome. Again, the patient will end up in the amenorrhea, right? So the third cause will be the uterine pathologies. So in the uterine pathologies, the FSH and estrogen will be normal. Please pay attention. In the uterine pathologies, the FSH and estrogen will be normal. Why? Because neither the uterus produces any hormone. It was the ovary producing the estrogen, and the estrogen was acting on the uterus. Uterus was not producing any hormone, nor the uterus is giving any negative or positive feedback to hypothalamus, pituitary or ovary. So here the FSH and estrogen will always be normal. So let's study Asherman in bit detail. In the Asherman, name itself is telling you Asherman, all hormones normal. Okay, so in case you forget the concept of that uterine pathologies, all the hormones are normal, Asherman is itself telling you that all the hormones are normal. Okay, now why Asherman happens? Why there are adhesions in the uterus? Whenever it is iatrogenic, whenever any doctor does an extensive curettage, then the in the during the extensive curettage, the endometrium gets derooted, gets removed from the root. Okay, so now when the endometrium has removed from the root, so in spite of estrogen is stimulation, this endometrium will not proliferate. So the patient lands up in the amenorrhea. And now, because now the uterus is unused, the uterus is not doing any function, the uterus is not uterus endometrium is not proliferating, so now the uterus develop adhesion. Same like in our unused rooms we develop cobwebs, right? Now when is this curettage done? So curettage is done in either in the PPH to remove the retained membranes or placenta, or post abortion to remove the products of conception. Okay, so the curettage is done in only these two conditions. So whenever they are giving you a question of Asherman, they will be giving you either the history of DNC directly, or they will be giving you history of PPH, or they will be giving you history of RPL or abortion. Okay, so these are the key points which they will be giving you. Okay, number one key point which they will be giving you is that all hormones are normal. Since Asherman etiology is extensive curettage, so they will be giving you second hint as history of DNC, history of PPH, RPL or abortion. Okay, now Asherman is more associated with the PPH curettage. Since when PPH happen, we do a extensive curettage quite often. Okay, now what is the clinical presentation? On each and every slide, they have asked you 2 or 3 questions in the exam. Now, the most common clinical presentation of Asherman is infertility. It is but obvious that when the patient's endometrium is not proliferating, the patient will land up into infertility. Patient cannot conceive if the endometrium is not proliferating. So, infertility is also the complaint of Asherman, and amenorrhea is also the complaint. But infertility being more serious problem, more affecting the patient, the most common complaint with the patient comes is infertility. Okay, now how in an infertile patient we get a hint that this infertility is due to the Asherman, since it is a very rare cause of infertility. Okay, so we routinely do a normal workup of the infertility patient, ruling out the most common cause of female infertility and ovulation. After that, when we are ruling the tubal patency by HCG, we get this HCG. We get the filling defects in the uterus due to the adhesions, which indicates that it is Asherman. So the in infertility, how we get the hint of that it is Asherman? Whenever we will rule out the second most common cause of infertility, tubal blockage, we will do a HCG to see whether tubes are patent and not, and we will get this filling defects, or it is also known as honeycomb appearance on the HCG. Since there are adhesions in the HCG, in the uterus, so wherever there will be adhesions, the dye will go there and we will get the filling defects. Now, what is basically the investigation of choice? HCG is not a confirmatory investigation. We will confirm it. Either we get the hint by filling defects of HSG in an infertile patient, or we get the hint in the amenorrhea patient with normal FSH and history of DNC. We have to confirm it by hysteroscopy, by visualizing those adhesions with a scope. Okay, and how we will manage it? We will remove those adhesions then and there only by hysteroscopy. Okay, and we will also put an intrauterine pediatric catheter so that the adhesions don't reoccur, and we will give a high dose estrogen to facilitate the endometrium proliferation. Now let's see the question. Women presents with amenorrhea and history of frequent abortion. So this is a case of secondary amenorrhea. Okay, FSH is normal, 7 international unit per ml. So this is clearly indicating that it is a uterine pathology. HCG less than 5 international unit per ml. This rules out that it is pregnancy. Right. Now, what is the option A? Pituitary disorder. In the pituitary disorder, FSH decreases. It is less than 5. In the ovarian disorder, FSH is more than 40. In uterine, FSH is normal. In the adrenal disorder, again we will get a deranged FSH, which is not in the scope of our syllabus. So the answer to this question is uterine syncytial. I hope you find this information valuable. Please do like, share and give honest feedback in the comment section. Do subscribe my channel for more information like this. Thank you.